Good morning, friends. I am Dr. Udayakiran, teaching you GIT. So today we'll be talking about how to approach a case of ascites, what are the different causes of ascites, how to manage it, what are the complications that are possible in ascites, and possible management of the complications also. This will be a lengthy class, which we'll be dealing it in 2 or 3 classes. So we'll go into the details of ascites. Okay. So ascites is so there's a potential space between the two layers of the peritoneum, the visceral and the parietal. Collection of the fluid in between these two spaces is called ascites. So in this slide you can see this is the visceral peritoneum is lining the internal organs, and the parietal peritoneum will be lining your abdominal wall. In between these two layers, fluid will be accumulated. Normally, little amount of fluid is present, but pathological accumulation of fluid in this space is called ascites. It can be due to different reasons. One of the most important is cirrhosis. So it is the cause of ascites in 85% of the population. 80% of people with ascites. So other causes are miscellaneous portal hypertension related disorders, which may not be due to cirrhosis. See, cirrhosis is not the only cause of portal hypertension. There are other causes like Budd-Chiari syndrome, alcoholic hepatitis. All of these cause portal hypertension. So the other causes of portal hypertension account for another 8%. Cardiac disease accounts for 3%. Peritoneal carcinomatosis 2%, and miscellaneous non-portal hypertension related 2%. So the cirrhosis, portal hypertension because of cirrhosis and not non-cirrhosis almost accounts for 93% of your ascites. So there should be other causes also. You should not be missing those when you diagnose a case of ascites. So how to differentiate between different causes and how to treat, we'll be dealing in the further sections. So what are the pathology and pathogenesis? So where is this fluid coming from? In a case of cirrhosis and portal hypertension related case of ascites, there will be leaking of fluid from the sinusoids. Normally, even in normal people, fluid will be leaking from the sinusoids and accumulating to the peritoneal space, but the lymphatics will be effectively able to drain out all this fluid. But in portal hypertension, because of the increased pressure within the sinusoids, lot of fluid will be leaking through the channels. So all lymphatics will not be able to handle all this fluid, and hence there is accumulation. And the other causes are blockage of the lymphatics. Even if normal amount of fluids are produced, when the lymphatics are blocked, this fluid cannot be drained. So that is another cause. The other causes are inflammation of the peritoneum itself. When there is infection of the peritoneum, when there is peritoneal carcinomatosis, when there is tubercular peritonitis, when there is secondary bacterial peritonitis because of the abdominal wall, because of the intestinal wall perforation, any bacterial accumulation in this and infection will cause accumulation of fluid. So these will behave in a different way, and these need treatment in a different way. So there can be mesenteric leaking. Some rare causes can may cause ascites in this way. So this is how this is the outline of the pathogenesis. How exactly it causes ascites in cirrhosis, we'll be dealing it in further slides. So this is about portal hypertension. The pathogenesis of ascites in portal hypertension. In portal hypertension, there is increased blood pressure within your portal vein. That results in damage to the endothelium or damage to the gut wall. This causes endotoxin escape. Just a minute. This causes escape of endotoxin into the mesenteric vessels, and this endotoxin will cause inflammation of your gut. That results in any inflammation results in vasodilation. Gut being a major or very lengthy organ, Vasodilation of it results in significant decrease in systemic blood pressure because all of your blood will get diverted to your intestine. So the mean arterial pressure falls down, resulting in decreased renal perfusion. Decreased renal perfusion results in renal sodium retention. Whenever the kidney is not receiving any blood, it thinks there is decreased blood inside the body and starts to retain fluid to compensate for the decrease in the volume of the intravascular volume. So there is renal sodium retention causing overfill. So lot of fluid is coming into the body now, but all of it is going into the splanchnic circulation in dilated vessels within the intestine. So this results in increased blood flow within the splanchnic circulation, but not the systemic circulation. And there is also fluid overload. All this fluid, when passing through the portal vein through the liver, will transfuse outside through your sinusoids and get ultimately settled in your peritoneal fluid. You understood? This is portal hypertension. Portal hypertension damages the gut wall. It results in endotoxin release from your normal intestinal flora. The endotoxin, because of the lysis of the bacteria through their normal life cycle, the endotoxin now, because through the leaky channels, will get released into the mesenteric veins. And this endotoxin will stimulate inflammation, resulting in significant splanchnic vasodilation, and hence your systemic blood pressure falls down because of this vasodilation. Because of the decreased perfusion of the kidney, secondary to decreased mean arterial pressure, the kidney starts retaining fluid. All this retained fluid will eventually pass out through the liver into the ascitic fluid. And your lymphatics will not be able to handle increased fluid percolation into the peritoneal sac, resulting in ascites. This is the mechanism for cirrhosis. Mechanisms differ in between different causes of ascites. Okay. So there is a grading. Normally grading of ascites. Grade 1 is mild, detectable by ultrasound. You cannot clinically appreciate this ascites. Grade 2 is when flank fullness. Whenever the patient lies down on the blood bed, when the flanks get dilated, distended, you'll be able to, and you are able to feel a dull note on percussion on the flanks. It's called grade 2. And grade 3 is when you say there is a fluid thrill. As you know, when you tap one side of the abdomen and you feel the thrill on the other side, then that means the fluid is very taut inside the abdomen. It is grade 3. There is another thing called refractory ascites. This doesn't belong to grading of ascites, but this is through whenever you treat ascites and it doesn't come down, you call refractory ascites. This is not done clinically. It doesn't belong to your clinical grading. So whenever you see a patient of ascites, you need to be able to differentiate what has caused this ascites. So there will be different clinical clues pointing you in the direction of the diagnosis. The first thing is cirrhosis, as we have covered it already in the last classes. Whenever there are spider angiomata, palmar erythema, muscle wasting, gynecomastia, deep contracture, asterixis, all the classical features of cirrhosis, jaundice, and when there is splenomegaly, you think the ascite is mainly because of cirrhosis. There can be overlapping conditions also, but we'll think about it as clinically. We'll think cirrhosis has caused this ascites. And the other causes, like I said, if there is infection within the peritoneal cavity, like when there is tuberculosis, the patient will be presenting you with a loss of appetite, fever, weight loss. There can be signs of immunosuppression in the patient because tuberculosis has rebounded. Normally, we'll have pulmonary tuberculosis, extrapulmonary, but whenever the patient is having peritoneal tuberculosis, there can be some signs of immunosuppression in that patient. Like the cirrhosis itself is an immunosuppressive state, which predisposes the patient to tubercular peritonitis. So whenever a patient with cirrhosis and abdominal distension suddenly comes to you with increased abdominal distension, fever and abdominal pain, we will not dismiss the patient as mere cirrhosis and ascites, but we will be suspecting tuberculosis also in such patients. In these patients, because there is a sudden worsening because of tuberculosis, but not because of cirrhosis, there will be no pedal edema. There will be only infection of the peritoneal cavity and abdominal distension. Whereas an ascites that is increasing because of only cirrhosis, will also be suspecting pedal edema. But in these patients, because of localized infection, there will be localized fluid collection only. And another cause of localized infection is secondary bacterial peritonitis. Whenever secondary bacterial peritonitis is when you say when there is intestinal injury and leakage of the intestinal contents into the peritoneal cavity, as your intestine is a source of vast number of bacteria, all these come into the peritoneal cavity and infect it, resulting in significant inflammation of the peritoneum and fluid exudation into the peritoneal cavity. That is another cause of your ascites. Third is the cardiac ascites. This also causes portal hypertension because your heart is not able to pump the fluid. There is increased back pressure. That back pressure will be transmitted to your portal liver and hence to portal vein, and hence you will have portal hypertension in these patients. This will also cause fluid translocation into the peritoneal cavity, similar to your cirrhosis. But in these patients, the clue is your neck veins will be distended. If at all the neck veins are not distended, any pressure on the liver, like hepatojugular reflex, when you press the liver, the fluid comes back to your neck veins, but your heart will not be able to effectively pump the blood, and so you will have positive hepatojugular reflex. So the patient will be having dyspnea, and examination of the heart will show some right heart or left heart failure. Right heart failure is definitely necessary for having distended neck veins. Whether it is the left heart failure that is causing the right heart failure or right heart failure alone is causing the distended veins can be found out through examination of the heart. There will be raised JVP. There will be positive hepatojugular reflex. Just like I told you, when you press the liver, the fluid goes into your neck veins, but it cannot be effectively pumped by your heart and will have a positive hepatojugular reflex. There can be also pedal edema. So this is about cardiac ascites. Another thing is pancreatic ascites. Inflammation of the peritoneal cavity need not be through infection. Any chemical inflammation of peritoneal cavity can also result in fluid translocation to the ascitic cavity. So what are the causes of chemical irritation? Endogenous. One is pancreatic fluid. As it digests anything that it comes into contact with, whenever it gets leaked into the abdominal cavity, it injures all the viscera. And also bile. Bile is also a lipid solvent. Whenever there is bile leak into the intestine, it also damages the peritoneum and causes inflammation. So peritoneal or pancreatic or bile leak both will cause inflammation and cause abdominal translocation of fluid. So why do they leak? There can be blunt trauma of the abdomen, or there can be acute pancreatitis because of any obstruction of the pancreatic duct, or it can be iatrogenic. Post surgery, there can be some leak in these ducts. So this is about chemical ascites, either can be because of pancreas or biliary leak. And another thing is malignant ascites. So if any carcinoma, if it gets translocated to peritoneal cavity, it spreads along the wall of the peritoneum, and this peritoneum will be inflamed because of the malignant tissue. They will infiltrate the peritoneum and also inflame the peritoneum, and this results in exudation of fluid into the peritoneal cavity. So commonly caused cancers commonly causing this peritoneal carcinomatosis are breast, bronchus, ovary and stomach. So this is how you the different causes of ascites and clinical clues to the cause of ascites. But how do you evaluate a patient of ascites and conclusively establish the diagnosis and cause of the ascites? So there are few tests that you do on the ascitic fluid, based on which we can differentiate it. So what do we do? So whenever a patient comes to you with grade 2 or above ascites, like in grade 2 is like when the flanks are full, not when there is grade 1 ascites, but when there is grade 2 or grade 3 or anything above it, you will do a diagnostic paracentesis. You will remove some amount of fluid and conduct some cytological and biochemical tests on them to establish the cause of ascites and to see if there are any complications in that ascites. Okay. So what are the tests that you do? Routine is cell count. You will see the number of neutrophils and cell count and differential also. Is it neutrophilic predominant? Is it lymphocyte predominant? What are the total number of leukocytes? We'll check for the amount of albumin and also total protein. So why do we do this? We'll be covering it in the further slides. And optional are amylase, culture in blood culture bottles, glucose, gram stain and LDH. If you suspect any infection or pancreatic cause of ascites, then we do these tests like amylase. When the amylase and lipase are elevated in the fluid, we think of it as pancreatic ascites. When culture will show any growth of when there you suspect any infection, any fever, abdominal tenderness. You suspect any, and there is perforation of intestinal viscera, abdominal viscera. You think you suspect an infection and you do a culture. So what are the organisms that grow and what organisms tell you what source of the infection is, we'll be dealing in further slides. So glucose, when the glucose is reduced, you think of it as bacterial infection. Gram stain, obviously you know what gram stain is for, LDH. So whenever you suspect biliary leak, you do bilirubin levels of the fluid also. Cytology, when you suspect cancer, TB smear and PCR test and ADA, adenosine deaminase, that you do when you suspect TB peritonitis, triglyceride levels, whenever you suspect lymphatic obstruction, and these are the other things that you can do. So we'll be going into the details further. So first thing, the basic things that we will be doing are cell count, albumin and protein. Cell count will tell you if there is any infection of the fluid. Albumin will tell you the source of fluid, whether it is because of cirrhosis and portal hypertension or other causes of portal hypertension or some inflammation as such. So this is a general algorithm like is given in Harrison. You can go in through the detail. I'll be coming back to this slide later after explaining to you what SAG is. Okay. So these are the general things about ascitic fluid sample. It is usually transparent and yellow, like golden yellow thing. If it is blood, it will be a slight blood tint because you are perforating the abdominal wall. Some amount of fluid may come into your syringe and it may cause some blood streaking. But if it is frankly bloody, you think of it as a ruptured hematoma or mostly carcinoma, peritoneal carcinomatosis or ruptured hematoma. Otherwise, slight amount of blood is okay because of the traumatized abdomen. So when it is cloudy, white cloudy, it is because mostly of chylomicrons and lipids within the fluid. It is mostly due to lymphatic obstruction. So all the fat that you eat will not go from the intestine into your blood. It rather goes into your lymphatics, and from the lymphatics it enters your thoracic duct and into the superior vena cava. So whenever there is obstruction of the lymphatics, all the fats get accumulated within your ascitic fluid. That is when you call it chylous ascites, and it is cloudy in them. Whenever it is green, you think bile leak. So this is cloudy chylous ascites. Turbid, milky or creamy peritoneal fluid due to the presence of thoracic or intestinal lymph. This lymph gets leaked into the abdominal cavity. So whenever you look in the microscope, you will be seeing flat fat globules that are supposed to be absorbed to the lymphatics, but rather they got obstructed and leaked back. So in these, when you do a triglyceride level, there will be more than 1000 mg per deciliter. So this is the most important topic: serum ascites albumin gradient. Whenever a patient comes with ascites, this is the first test you need to do. You will do an albumin level inside the ascitic fluid, and at the same time you will be doing the albumin level in your serum, and the gradient between these two is called ascites albumin gradient. So what does this tell you? This tells you essentially if your ascitic fluid is because of portal hypertension or because of any localized causes of inflammation. So normally your Starling's laws, what they tell you, your oncotic pressure within the blood vessel is counters the hydrostatic pressure. Inside your blood vessel, the hydrostatic pressure is high, so the fluid wants to go out. But your albumin within the blood vessels will counter this because of your osmotic gradient, will want to preserve the fluid within the blood vessels, and so your fluid balance is maintained. Whenever the hydrostatic pressure increases more than normal, your oncotic pressure cannot compensate for this increased hydrostatic pressure and fluid starts to leak out. So when the ascitic albumin gradient, so this fluid, when it goes into the peritoneum, it will not have any albumin within itself. It's going out because of the hydrostatic pressure, but not because of leaky channels. Okay, because the hydrostatic pressure has increased, fluid just percolates outside. So this is in that fluid there will not be any albumin, but your albumin will be present within the blood vessels. So the difference in the albumin gradient within the blood vessel and out in the abdominal cavity will be significant. So when the serum ascites albumin gradient is more than 1.1, you say it is because of portal hypertension. Whenever there is hydrostatic pressure, fluid just leak out without taking albumin with itself. So if its sag is more than 1.1, you call it as high sag ascites, and you think of the reason as due to portal hypertension. And whenever the sag is less than 1.1, for example, think of it as decreased oncotic pressure. Whenever the albumin comes down within the blood vessels, or when there is inflammation within the peritoneal wall, fluid just leaks out, and in these cases, the sag will be less than 1.1. So this sag tells you what is the source of your ascitic fluid. The accuracy of sag results in approximately 97%. You will be able to classify ascites. So if the slag is 1.1 or more, greater than or equal to, here it is 1.1 or more, you call it as high sag ascites. This is calculated by subtracting the ascitic fluid albumin from serum albumin. So this is the formula. So measurement of ascitic and albumin concentration has been routine in some laboratories in 1980s. Initially what we used to do, we used to call it transudate, exudate, LDH. We used to measure LDH and based on this we used to call it exudated transudate. But that concept is gone now. We'll be doing only SAG in these patients. So high gradient is more than 1.1. See, all these cases have portal hypertension in common. So whenever there is alcoholic hepatitis, there is swelling of hepatocytes and compression of sinusoids. In Budd-Chiari syndrome, there is obstruction of the hepatic vein causing portal hypertension. Cardiac ascites because of the back pressure from the heart and to the hepatic vein and into the portal vein, there will be portal hypertension. In cirrhosis, anyway, you know, because of the fibrosis, there will be portal hypertension. Fatty liver of pregnancy because of the distended hepatocytes. In fulminant hepatic failure because of the vasoconstriction within the hepatic sinusoids and the crumpling of the liver. And within liver metastasis, these all can compress your sinusoids, hepatic vein, portal vein. And when there is mixed ascites, there can be portal hypertension and some inflammatory process also. Like for example, when there is cirrhosis, and on top of that, if there is tubercular peritonitis, that we call it as mixed. So even in those patients, in those mixed patients, your SAGs will still be high because if there is portal hypertension, your SAG will be high. You cannot think like because there is tubercular peritonitis also, the SAG may be low. No, it doesn't happen like that. If there is a portal hypertension, your SAG will be high. And there is mixed edema, portal vein thrombosis, sinusoidal obstruction syndrome. In all these cases, you have a common denominator, that is portal hypertension. Whereas you see in the low gradient ascites, like when the SAG is less than 1.1, one is biliary ascites. Like I said, chemical ascites because of the inflammation of the peritoneum. Bowel wall infection or obstruction. This causes translocation of bacteria into the abdominal cavity and causes inflammation of the peritoneum. And nephrotic syndrome, because there is a total decrease in the amount of protein within the blood, your fluid will start translocating. Pancreatic ascites and carcinoma of peritoneal carcinomatosis, postoperative lymphatic leak, serositis in connective tissue disorders. In some connective tissue disorders, you will have inflammation of the peritoneum, all peritoneal cavities, synovial cavities, everything you will have inflammation. And in those also, you will have fluid in the abdominal cavity and tubercular peritonitis. So whatever, if there is localized inflammation within the peritoneal cavity, you will have low SAG ascites. It's less than 1.1. Okay. So based on this, we can classify. We can identify what has caused their ascites. Just a minute. We'll go here. Glucose and LDH. So glucose is consumed by your neutrophils. Neutrophil source of energy is glucose. Whenever there are increased neutrophils within your lymphocytes and neutrophils within your abdominal cavity, not lymphocytes, only neutrophils in the abdominal cavity, your glucose content will be low. So when do the neutrophils come into the abdominal cavity? When there is infection or severe inflammation. So these neutrophils consume glucose and will be low. So this usually low glucose points towards an infection. And LDH. LDH is a larger molecule than glucose, enters ascitic fluid with difficulty. So whenever there is inflammation of the peritoneal cavity, because of the leaky channels, and your LDH may be leaking into the abdominal cavity. This doesn't hold much significance in nowadays. It's mostly based on glucose, neutrophils, and albumin. We'll classify. Other tests, like I said, amylase. Uncomplicated cirrhotic ascites usually normally 40 international units per liter, but in pancreatic ascites, because of the leak of amylase lipase into the body, you will be having around 2000 international units per liter. Triglycerides, when they are increased, it's called chylous ascites. So tests for TB, whenever you do a gram stain, because TB is a slow growing bacteria, you will not have significant amount of bacteria within your peritoneal cavity. You will not have. So you may not be able to find out through a smear. And cultural also, because they are slow growing and very facultative and the fluid is very less in number of bacteria, it may not achieve 100% results. So how do you diagnose? When there is lymphocyte predominant leukocytosis in the abdominal cavity, and this enzyme adenosine deaminase, this is present in the lymphocytes. So whenever this enzyme is increased inside the peritoneal fluid, you think of it as TB. Cytology, you take fluid, you centrifuge it, take the cells and observe under a microscope. You may find carcinomatous cells. You may not find. If you find it, it is no doubt carcinoma, and you almost always find it in almost all cases of peritoneal carcinomatosis. So you can do an ultrasound, you can do a CT. By these, you can differentiate what is the cause of your portal hypertension. And you can do a Doppler ultrasound to find out if there is obstruction of your hepatic vein and hence flow of the blood within the hepatic vein, that is Budd-Chiari syndrome. So we'll talk about different causes, complications of. So whenever you do a acid tap, abdominal tap, you should look for the gross appearance of fluid, transparent yellow, crystal clear, or cloudy yellow. Based on this, I said this is normal. Transparent yellow is normal. Crystal clear, that is also a normal variant. And then it is cloudy yellow. There, it can be because of increase in neutrophils, or it can be because of the triglyceride accumulation. When it is bloody, you think of it as either traumatic tap, or there can because of carcinomatosis, metastasis. If it is milky, you can think of triglyceride concentration dark brown. You think it may be because of bilirubin. This is based on gross appearance. So when you have white blood cell count, if it is more than 500 or less than 500, when it is more than 500, you look for the amount of neutrophils. If it is more than 50%, then of it, more than 250 is polymorphonuclear neutrophils. So whenever you do WBC count and see if WBC counts are more than 250 or less than 250. If it is more than 250, then it may be because of infection or inflammation. It is one of the important differentiating factors. When you do a cell count, you will be looking for neutrophils. So when the neutrophils are high and the SAG is low, you think of an infection of the ascitic cavity. Neutrophils are high, then you know there is an infection. And you do a SAG, it is more than 1.1 or less than 1.1. If it is less than 1.1, then you think it is only the local inflammation that is causing ascites. What is the local inflammation? Cause of local inflammation? There can be bacterial translocation from the intestine into the ascitic cavity because of the abdominal trauma. There can be pancreatic ascites, bilious ascites. All of these cause, look at here. secondary bacterial peritonitis or pancreatitis, local inflammation of the peritoneal cavity and hence ascites. So, but whenever their SAG is more than 1.1, there is, now you say there is portal hypertension also. Portal hypertension is causing ascites, but your neutrophils are also high. So what is it because of? That means your portal fluid is infected, probably because of some bacteria that has translocated from the abdominal into the abdominal cavity. That is called spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis is nothing but spontaneous infection of your peritoneal fluid. When does this happen? See, in patients with ascites, because the ascitic fluid doesn't have any opsonins or any low in immunoglobulins, low in proteins, bacteria can easily grow. So whenever spontaneously some organism is going through lymphatics and mesenteric lymph nodes, if it accidentally gets translocated within your abdominal cavity, it infects your uh, peritoneal fluid, but not peritoneum. It infects the peritoneal fluid. That is called spontaneous bacterial peritonitis. It is seen in patients of ascites. So, whenever such thing happens, when you have ascites, when the SAG is more than 1.1, but your neutrophil content is also increased within the ascitic fluid, you think of it as spontaneous peritoneal peritonitis. Differentiate it from secondary bacterial peritonitis. Here it is because of abdominal infarction or abdominal trauma or perforation causing leak of bacteria. Here bacteria may spontaneously enter. Okay, this is polymicrobial, this is monomicrobial. Only one kind of organism, usually E. coli, grows. In this many kinds of organisms grow. So this is about SBP. I will be dealing with this in detail in further classes. So we'll come back to this slide again. I think this is enough for today's class. So here you need to remember the SAG and the neutrophil count. This is the basic test we do anyway. I told you you do cytology, you do SAG. So whenever it is more than 250 and SAG is less than 1.1, you think of it as local infection. It can be because of secondary bacterial peritonitis or it can be pancreatic ascites. When the SAG is high, you think of it as spontaneous bacterial peritonitis. The other columns will be dealing it in the next class. Okay. Thank you guys.